All right. Hello, everybody. I'm Chris Urbanek. I'm one of the physicians at Regenexx Des Moines, and welcome to our lunchtime webinar where we're going to be talking about low back pain today. And as you can imagine, low back pain is a very broad topic where literally week-long conferences are being held discussing just low back pain. And we're going to try to cover what we can in about a half hour or so. So this will give kind of a broad overview about what options we may have and some of the other options that are out there, and what can prove to be beneficial and what may actually be harmful. So with that being said, we're going to go ahead and let me share my screen, and we're going to open up kind of a quick PowerPoint. And so again, as I said, we'll be talking about low back pain. If you do have questions or thoughts kind of throughout this webinar, go ahead and put them into the chat. I will review all of them at the end, so you don't have to worry about getting kind of lost in other people's questions. So please feel free to add those in. And let's get started. We're going to talk about, is not there. We go. We're going to talk about the lower back. And so this is a very general schematic that we're actually going to spend a little bit of time kind of looking at these pictures and talking about what all is involved in low back pain. There are many causes. This slide in general is specific to disc pain, which is a common complaint or concern that I hear from patients. They say, hey, did I tear a disc, or do I have a disc bulge, or is it a herniation? And what's the difference kind of between all of those terms? So we're going to address the disc questions today, but I also want to talk a little bit about spinal anatomy. And so this is a really great kind of schematic that Dr. Centeno kind of put together. And as we kind of look on the screen here, the blue squares are our vertebral bodies. Now that's the building block that our spine is made out of. We have sequential vertebral bodies, one sitting on top of the other, from the base of our skull all the way down to our sacrum. And between each of those vertebral bodies, in this schematic is a gray area. That's our intervertebral disc. And that really acts like the shock absorber between the two. And because it's more flexible than bone, that's what gives us our motion. So it allows us to bend forward, turn side to side. And because we stand and sit upright, it's our shock absorber. And again, that's kind of where we see a lot of the questions coming from as far as disc pathology. The yellow in this schematic is our spinal cord in the middle. So this again runs all the way up and down. It goes from our brain to the base of our sacrum and out all the way to the ends of our fingertips and toes. And so in the center, we see the spinal cord. And then coming off to the spine, off the side, is a spinal root. And so those are the nerves that individually go out to our appendages, and they all come out at specific levels. And one of the ways that we can identify where a problem in the back is by where the pain is occurring. And so because that happens at specific spinal levels, we can say, you have numbness in your thumb, it's this cervical level, or oh, your big toe doesn't go up as well as it used to, it's this lumbar level. So that can point us kind of in the direction of which nerves are certainly involved. And then you can see that there's an overlap in this schematic between these blue pieces, and these are what are called the facet joints at the back. And the facets are very much like shingles. Now the alignment changes, whether we're talking about in the neck or the mid back or the low back, but you can really think of them as essentially overlying pieces of bone that sit like two flat discs with cartilage between them. And they support the posterior elements of the back, which again are these structures, the facets and the spinous process, which would be kind of sitting in the middle of it. And the spinous process is simply the bumps that you see on someone's back when they don't have a shirt on, or if you're at the pool or the beach, and that kind of sits throughout the middle. The facets are kind of have some motion to them, and they are an articular process, meaning that they have cartilage, as I said, and they support kind of the backside. So we have stability from the vertebral body being bone, with a freedom of motion because the disc is mobile and can move around, and the facets will kind of slide on each other and create motion as well. And so that's where we get kind of our spinal motion from. And so if we kind of look at our examples here, I'm going to start with the second one in. This is our bulging disc. And you can see blue vertebral body above, blue vertebral body below, and in the middle there's gray. And in this instance, the gray is shooting backwards, and it's coming into contact with the nerve as it comes out the side. And so this would reproduce some sort of symptoms. If this is in the low back, this may give burning into the buttocks, the hip, the front of the thigh, back of the thigh, even down into the foot. And often this is what patients refer to as sciatica. Those symptoms that the origin of the symptoms is in one place, and it creates a sensation somewhere else. We call that radiculopathy. And so it's not always coming from the sciatic nerve, but can come from the nerve roots that live in the back. And so this is a pretty typical bulge. This can happen from wear and tear. The classic kind of comparison of what a disc is made of, or what the consistency is in medicine, even in med school, we really describe it as a jelly donut. On the outside is the dough, which gives some structure to it, and in the very middle is a jelly nucleus that provides some of that shock absorbency. And so when you're getting stretching of the outside of that donut, which can be from wear and tear, it could be from a sudden trauma, it becomes less stable and starts to push back towards the nerve. Now, there's lots of different ways that the disc can be involved. So this is typically what we call a disc bulge, or posterior disc bulge. You can also get a herniation. Some people call this sequestration as well. And what that means is basically the jelly that should be in the smack middle of the disc leaks out through what is typically a small tear. And then that nucleus, the nucleus pulposus, or center of the disc, is essentially an irritant. So it creates an inflammatory response. Not only does it irritate the nerve because it's directly pressing on it, but also because those chemicals that are typically contained within the disc are now reacting with the environment that the nerve lives in. And so that can produce symptoms of either central low back pain or radicular pain as well. And we can compare that to just an isolated tear. And so that's our third picture over. Again, blue vertebral body, gray disc, blue vertebral body, and now we see this white line through it. And that's almost exactly the way that tears look like on MRI. And I think we have some examples that we'll show you here a little bit later. And this again can happen from trauma. It can also happen from wear and tear, where a stretched or irritated disc, like we see in the second picture, over time develops tears in it. And these are typically painful as well. This typically involves more of what we call axial low back pain, central low back pain, because you can see that there's nothing impinging in the area where the nerve lives, which again, yellow is our spinal cord, and the roots come off from the sides. And so nothing really kind of gets back in there, but there are instances where even a torn disc like this without a bulge can cause some nerve irritation, because you see pro-inflammatory chemicals that are part of that injury and the resultant healing process. And so again, that's our disc tear. And then our last one is really probably the most common we see. And any of these can really come in concert with others. So this is a degenerative disc. So early in kind of the wear and tear process of our disc, we see that it'll lose disc height, meaning that the vertebral body above it and the vertebral body below it become closer together. The disc typically gets darker because in the MRI sequences that we're using to look at it, fluid shows up as bright white. And so as we see less fluid, the disc itself becomes darker. And so the disc itself, yes, is getting injured and can cause some pain from this regard, but we also have to be kind of cognizant of what else is involved in this spinal picture. So when we talk about spine, or if you're seeing any spine providers, they may use the term functional spinal unit, and we'll talk a little bit more about that. The whole idea of the functional spinal unit is that really nothing is in isolation. It's not just the disc injury. It's not just the nerve entrapment. So if you lose disc height, and your facet joints, or the shingles of the low back that we talked about, are usually sitting in this kind of alignment, we've now shortened the span that they typically go through, but we haven't changed their bony length. So this spinous, this articular process is the same length as it always was, but now there's less gap between the one below and the one above. So the facets, or the shingles, the joints of the back, are being more pressed against each other. They're becoming more irritated. And we'll talk even more, these red squiggles on the side here, these are our ligaments that stabilize the back of our back. And they too act like a bridge that's now had the road shortened. The cables are the same length, but the relationship between the two is less. So now these ligaments are all placed on slack, which perpetuates what happens at the facet joint, because now they have more freedom. So now there's more motion at the facet joint, which also means there's more stress back onto the disc. So we get into this positive feedback loop of worsening symptoms, worsening back conditions. So as we're kind of talking about some of the spine stuff, I want to keep this schematic in mind of vertebral bodies and disc, facet joints or shingles in the back, the nerve coming out between those two, and then the ligaments providing some stability. And then we're going to add one extra thing onto that at the end as well, but we're going to start kind of with this concept. So this is a relatively busy side. Ignore the text off to the side for a second, and let's just kind of talk about what we're seeing here. The picture on the left is an MRI, And if you've ever had an MRI before, the vast majority are done lying down, typically on your back. The picture next to it is an X-ray of a low back, and these are typically done standing. And so what we want to look at here is some of that base anatomy that we just talked about and how things can change depending on how we're looking at it. So again, let's go to the MRI. These vertebral bodies are numbered according to their level. So lumbar vertebrae 1, lumbar vertebrae 2, and so on all the way down to the sacrum, which is at the very bottom. And you can see that, again, the vertebral body bone is all similar texture. The disc that sits between it is a different color. And the most kind of normal looking one on here is this L5S1 disc, in that the lining of the disc is dark black. That's kind of the outside of our jelly donut. And the inside is white because there's more fluid, and that's the jelly in the jelly donut. Even this disc has a little bit of trouble. You can see it's developing a beer belly on the backside here. And but our real culprit, the one that's very different from all of the others, is this L4, L5 disc. And again, I just want to go back and kind of think about that schematic. This is really what we're looking for when it comes to the disc. We can't see the facets well in this picture because the MRI is taken in the very, very middle of the spine, and those facets or shingle joints live off slightly to the sides. So those aren't included in this picture. But what you can see is the spinal cord running through the middle. And you can actually see some of the ligaments back here touching between these spinous processes and holding them together. So this is kind of the duct tape that holds the spine together on the backside. And the comparison and why we're kind of talking about this is, an MRI is a static picture. It's a snapshot of the back, and it's in a gravity eliminated position. So we're only seeing kind of one particular thing here, but most of us with back pain would say that, yeah, when I'm up and walking around, or if I'm sitting, that's when I get that heavy sensation, that burning sensation, or the symptoms start to go down my legs. But we're imaging it in a totally different plane. And so compare that to an upright X-ray, where we're looking at the same patient with the same view, looking at the spine from the side. The back of every vertebral body has been outlined in yellow here to show a rough estimate of their alignment. And just comparing those yellow lines from the left picture and the right picture, you can see that on the right, there's more of a pronounced curve. This is giving us more information about the dynamic nature of the back. Many of us Regenexx physicians will get what's called multiplanar, multi-positional views of the back. So we'll do it from the side like this, but we'll also add flexion, having the patient bend forward and have the patient go back into extension. And we're looking to see, how does this alignment change? Because that's giving us information about the integrity of both the disc, the facet joints, and the ligaments holding everything together on the backside. And that's part of our kind of holistic approach to treating the spine. It's not just one thing in isolation that we treat. So yes, if you have a pinched nerve or a bulged disc, the traditional approach has always been, well, let's block the pain signal coming from that one area and see if we can get patients better. And it oftentimes resolves symptoms for a short period of time, but it doesn't change the underlying problem that we've lost disc height. So we've created instability. We've shortened the span that the ligaments have to cover, so they're now loose, and we've increased the stress on the facets. And that, in a nutshell, is basically the functional spinal unit. Okay. Since we're talking about discs, I did want to address just briefly at this time kind of what it looks like when we do some treatments. So the pictures on the left, both top and bottom, that have the red marks on them, are a patient that was prior to their treatment. And then on the right side is a patient, same patient, but post-treatment, so after we were able to treat the disc. And these are kind of great examples of exactly what we're looking at. So we can see disc herniation through this area, big disc bulge. When we look at it from the side, or from the top down, excuse me, you can see this brightness. So the round area up at the top is part of the disc, part of the vertebral body. And then we can see the disc bulge sticking towards the spinal cord, which is this area down here. And then you can see this brightness through it, which we call a high intensity zone. That basically means that there's a tear in the disc as well. And as we were talking about with that first schematic, you can see multiple syndromes or disc conditions all overlapping each other. So we've got loss of disc height, bulge, and a tear as well. And then here's 5 months after one of our Regenexx treatments, where we see recession of the disc bulge. So, the other comparison, the bright white, this is the fluid within the spinal cord. We're at a very low level, so there's not cord in this area, there's just the nerves. you can see that it's indenting the sac that holds that fluid together. So quite a large, effect on what we call the thecal sac. And over here, nice smooth transition. The front edge of that white where the fluid lives is now not being pressed on at all. And when we look at that top-down view, we see that this bulge is recessed. We see less of that whiteness where the tear represents, and much more space kind of throughout where the spinal cord here is. And this is just 5 months apart, and so great outcomes, certainly in these pictures. And that's typically what we expect with our treatments. We'll talk a little bit about what the specific treatments look like later on. We do treat around the nerves. We can treat into the disc. We can treat the joints, and we can treat all of those ligaments that I was talking about before. So let's talk about some typical management or what's commonly done. And if you're listening, you may have had this in the past. But epidural steroid injections. Now, these are a little bit different from like a labor epidural. We're trying to induce numbness during a pregnancy. Epidural basically means the space around the nerves. And so it's more of a location than like a thing. And so in typical practice, you'll see patients will have steroid injections. They will inject high dose steroid. Part of the problem with that is that our body naturally makes steroid. We have that system. So when there's stress or injury, our body protects itself by releasing steroid to help calm things down so we don't get an overactive response. The doses that are commonly used, both in the spine as well as in peripheral joints like knees and shoulders, are about 1 million times higher than what your body naturally produces. So it's an incredibly high, we call it super physiologic dose of steroids. And that comes with some side effects too. When you get these steroid injections, they're essentially a nerve block. They stop the nerves from sending their signal. So we've treated the symptoms that you came in with, but it hasn't done anything to treat the underlying cause, which means that it's more likely to progress because now you're not using pain as a protective mechanism either, and you're going to kind of further facilitate wear and tear. It is temporary. Most steroid injections will go about 3 to 4 months. And if you've had some of these spinal injections, your physician may have told you, hey, we can only do this 3 times a year or 4 times a year. And that's because of the side effects of the steroid. And so that's what we get to with damage of the supporting structures. Steroids cause collagen to start to break down. And again, if we're looking at a picture where the disc height is already being lost, meaning the collagen is not as supportive as it once was, the ligaments are now lax, and we need them to actually be tighter and stronger, but we're adding steroid into that area, and those ligaments are getting looser. That perpetuates and kind of further advances the disease that's already in that area. So while it takes the symptoms away, not only does it not address the underlying problem, but it perpetuates the injury that's already there. And then some studies have shown that spinal fracture risk actually goes up. We know that steroids decrease bone density. That happens if you're taking steroids by mouth or getting it by injection. The bone density decreases as a response to that. And there's one study that showed almost 30% increased risk of spinal fracture with each steroid injection. So it has a cumulative effect as well. And as I said already, these steroid injections, while they can manage the symptoms, they don't do anything to really address the total problem of that functional spinal unit and making it more supportive and less painful. Another thing that's done fairly frequently, and many of our patients come in having already had, is a radiofrequency ablation, or an RFA. And so the idea with the RFA is you take a needle that's slightly larger, but it has a tip to it that can heat up, and you advance it to the level of the nerve in the back that sends signals from certain areas, most commonly the facet joints or those shingle joints. And you can see on this picture on the right side, this is a posterior view, so looking from back to front of the spine. This is our spinous process or bump that we see, again, when you don't have a shirt on. Here's the transverse process, the bit that sticks out, ligaments attached between these as well. And then where this kind of white outline is the facet joint. This is the shingle of essentially the back. And so there are nerves that as they come out, they wrap around and they go towards the facet joint. It's what gives kind of the pain sensation that we feel from the joint. Some of these nerves also go to the muscles that sit right up against the spinous process and this part of bone that's called the lamina. And the muscles that live here span between the vertebral bodies. So we've talked about in some of our other webinars, there's 2 stabilizing systems in the body. There's what are called static stabilizers, meaning structures that are in place that are not intended to change in length. They have a static responsibility for stability. And that's stuff like ligaments. And so the ligaments are supposed to stay one shape and not really shorten or lengthen. And then we have a dynamic stabilized system that kicks in to address our movement needs. And so that's like the muscles. And in particular, we talk about the lumbar multifidi, muscle group that goes from one of these to the one above it. And this gives us our ability here. Well, these nerves that first go to the joint, secondarily go to the muscle. And so if we have this procedure where we take a needle and we literally burn or kill the nerve, yes, we can decrease the pain signals that are coming from that facet, but we're also turning off the muscles that give us our stability. So again, this frequently happens in settings of arthritis of those facet joints, laxity of the back, loss of disc height. And so those ligaments are already not doing their job because they're loose, and that's our static stabilizing system gone. Now we're turning off our dynamic stabilizing system as well, which is further going to progress our disease. Efficacy is largely debated with these RFAs, and many studies showing that they're really no more effective than physical therapy is. It's a destructive process. So we've talked in the past about things like meniscus surgery and having part of the meniscus taken out. And so, in that case, you're removing a vital part of your knee. It's your natural anatomy that's being taken out. And this is a similar case. We're literally burning and killing the nerve. And over time, this does regrow. We often see the pain signals come back after about 6 months or so. And it's even longer to get the muscles to come back because they're further away. Nerves grow at a given rate based off their location. So if we burn the nerve, it'll slowly regrow to the joint. And then if you give it time, it'll slowly regrow to the muscle. But typically around the time that it's regrown to the joint, patients are saying, hey, I need another treatment. And we're burning it before any of that nerve signal can come back to these muscles that are back here. It does provide some short-term relief. Like I said, it's typically about 6 months. And I've had some patients say, oh, well, the doctor that I saw that did my ablation told me that it's only the nerve to the joint. And that may not be entirely true. And there's one study, which I cited down here, it's very wordy. But basically, the premise of this study says that your radiofrequency ablation is more effective when they document that it's completely burned the nerve and there's no muscle activity in these muscles. So you can't have it both ways. You can't have a you can't have a procedure that only affects the facet joint that spares the multifidi. If you do, then it's unlikely to be effective for your pain in the first place and shouldn't do it. But if you do have benefit, if it is reducing your symptoms, then it has to have stopped the multifidi muscle from working. So again, we need to always kind of think about stepping back and looking at this whole functional spinal unit, because treating just one thing in isolation may affect some other areas in a negative manner, and that's part of kind of our treatment algorithm. This is an interesting picture of the lumbar multifidi muscles. It is red, which we have not seen on MRI yet, and that's because we used a sophisticated computer program to equal or make equivalent different MRIs, so MRIs that were done at different times of the same patient and at the same level. So this is an example of a lumbar multifidi that's been standardized through the MRIs at different time points before one of our treatments and after one of our treatments. And this is a patient that did not have radiofrequency ablation. They have inhibition of their nerves to their multifidi because of their arthritis. So just from the arthritis being there, the nerves are starting to turn off. In the picture on the left, all of the red that's contained within the yellow circle is essentially muscle. All of the white is essentially fat. And so when we run the numbers based off of this cross-sectional area or volume of the lumbar multifidi muscle, it gives us about a third of this muscle has turned to fat because the nerve running around this corner has gotten turned off. When we look at kind of a post-treatment, and this is 6 months after treatment, the coloring is identical. Red is going to be muscle, white is going to be fat, and the muscle itself is outlined by this red area. And what we see is that a drastic decrease in the fat content of the muscle and an increase in the muscle size as well. And so again, this is computer software calculating and gives us a lot of really good information as far as kind of how we can turn these muscles back on even with our treatments. Now, what's kind of the end game if everything fails? We're looking at spinal fusion. And so we'll kind of compare this to our first schematic that we looked at, though the colors are essentially reversed. The vertebral body are these gray areas representing these squares offset by the blue, which is our intervertebral disc. And at one of these levels, we have black hardware. This is metal that goes into the body, into the pedicle of each of these vertebral bodies. and holds them together. And so now there's no motion at this disc. It can't irritate you in certain positions. It can't flare up your pain. But these bones are essentially stuck in this position. You have no motion here. So the facets can't do anything. They can't open or close. You can't bend or flex there. But we all have to do kind of our day-to-day life. We have to tie our shoes. We have to pick up objects, right? And so we will induce motion. But if it can't occur here because there's a metal rod spanning that gap, then more of it has to occur at the level above or the level below. And that's what we call adjacent segment disease. And essentially, this is very common after spinal fusion. And the numbers are here as well. So 10% of patients with a lumbar fusion will develop adjacent segment disease at 5 years, and a little over 50% of patients will develop it at 10 years. So it's very, very common and something that we see in our clinic quite a bit. The other thing is that just like some of the other treatments, the benefit has shown to be pretty minimal. Most patients do find an improvement in pain and function within about a year, but you've also got several months of recovery that are part of that. And then really equal to physical therapy or therapeutic exercise at the 2 and 5 year marks. So you had the procedure, you had about, let's just say, a full year of relief, we'll be generous, from the spinal fusion. And then at 2 years, we're starting to see pain return that would be no different from with you have physical therapy. But now you've also lost motion at one level, and all of the things that you're doing are placing increased stress on the level above and the level below. Plus, there's surgical complications. So this is full anesthesia. Anesthesiologist has to intubate you. They breathe for you. You have the medications that cause that. Tissue is cut. So in order to get down to the pedicle, to this level where the hardware goes through from the backside into the vertebral body, they have to cut through things. And so what are those things? Ligaments that stabilize our back, and the muscles that are the dynamic stabilizers of our back. So those become injured, and oftentimes irrevocably so, at least from what we see in our clinic. So while you can get some short-lived relief, you're probably kicking the can, so to speak, in that the symptoms are going to get worse later. So let's look at kind of how the Regenexx approach does for this. This is data that was done, collected by Dr. Williams when he did his fellowship at Centeno Schultz. He's now down in Atlanta, and he's a brilliant physician. And so he took a look at the data that we collected in our registry, and he said, well, are there patients that we only treated their back arthritis by treating just in the joint? And there were some. And so you can see the numbers. So this area where it says ends, these are the number of patients that responded to our registry at each time point. And so for the lumbar facet or back joint only patients, we can kind of see their improvement through here. And so this is a pain score on the left. This is a function score on the right. And again, you can see the numbers of patients that responded at each of the time points. At the bottom, he said, okay, well, let's compare those patients that only had the joints injected compared to the patients that we treat as far as what we call functional spinal unit. We treat the ligaments, we treat around the nerve, we treat into the joint. And sometimes we treat into the disc as well if needed. And when we compare the two, which is a wonderful comparison because it's using our system of processing platelets, what we see is that patients do get improvement just by treating the joint. And that treatment trends out, or I'm sorry, the improvement trends out over about a year to a year and a half, and then they slowly start to return back. And so that's the same with both pain and function. So when we treat the entire complex, they get essentially the same degree of improvement that trends out for the same period of time, but then doesn't round back. It never kind of starts to trend back into worsening pain again. And so, well, why is that? It's that functional spinal unit. When we're just treating the facets, we're treating the arthritis, which we know gets better with platelet-based treatments or even bone marrow-based treatments. And so we're treating symptomatically and functionally the cartilage, but we haven't changed how those joints move against one each other because we haven't treated the ligaments, haven't treated the disc, haven't treated around the nerve. But when we add those on, because now we're changing the mechanics of the back, we're seeing persistent outcomes. So these patients are able to maintain their stability. They don't fall back into kind of a wobbly pattern where they're stressing the joint even more. And we see longer lasting outcomes. And I really like this data because it's done with our own processing technique. If this was a steroid graft, the improvement would be, starting at the same point, they'd get improvement. It would come down to somewhere between 1 and 3 months, and then it would come right back to where it was. And the hard part is a lot of those studies don't follow the patients out any longer than that. But given this functional spinal model, what I would expect is that they have pain with improvement that lasts 1 to 3 months, comes back to baseline, and then over time, it's going to continue to trend in the negative direction because all we've done is cover the symptoms. The underlying mechanical changes aren't getting any better. And so that's kind of the ballpark on what part of our treatment looks like. And we typically have conversations with our patients as far as whether we use platelets or whether we use bone marrow cells or whether we inject into the disc or not inject into the disc. That's a little bit higher level, and that's something I kind of wanted to avoid talking about today, and just give kind of a brief overview about perspectives on treatment and maybe some of the things that you want to reconsider if you're having input from other physicians saying, oh, I think an epidural injection of steroid is the best approach for you. So that's it kind of from my end of things today. Certainly, if anyone has any questions, please feel free to put them into the chat. I'm going to stop my screen sharing. And I did get a couple of emails in advance that I do want to address. So bear with me. I'm going to pull up the chat screen. So if you have questions, whether it pertains to low back or anything in general, you're more than welcome to. Please send those on to me. I want to pull up. So we had a couple of questions, and we'll see if anyone's in the room. But Miranda emailed and said, can you inject stem cells into my sciatic nerve, and does it hurt? So this is a really good question, and something that we can certainly address more down the road. So oftentimes patients will see their medical provider and they'll be told, oh, you have sciatica, and an often portrayed kind of etiology for their pain or source of their pain. They say, oh, you've got a tight piriformis. You've got the piriformis is pushing on your sciatic nerve. And I can tell you in my years that I've maybe seen 2 or 3 cases where that's actually the cause. Most of the time it's coming from the spinal nerve coming out of the back. And that can either be from joint arthritis, narrowing of the spinal canal called spinal stenosis, or from a disc that's pushing on that. And the disc and arthritis are really probably the 2 big ones. And so we use this term sciatica as more of a colloquialism than an actual medical diagnosis. The medical diagnosis is you have lumbar radiculopathy, and that's what's causing pain to shoot down the side. And so your treatment would probably be directed more at the back, and we'd have to schedule an appointment to, fine tune it for you, as far as whether we're just doing an injection around the nerve with something like platelet lysate, whether we're treating the joints, but certainly going to look at it from that functional spinal unit. Like I said, I have seen a couple of cases where the sciatic nerve has been injured, and those are typically big motor vehicle traumas or previous surgery, which has scarred around the nerve. And just to completely answer the question, yes, we can inject around the sciatic nerve as well, if that's where the pain's coming from. But a good physical exam and some imaging is going to point us in the right direction. And does it hurt? No, it typically does not hurt. There are some needle sticks, but we use very, very tiny needles, and we numb you up beforehand. And depending on your level of comfort and certainly how well you tolerate that, we have some things that we can do to make the procedure more comfortable for you. We sometimes can give some medications prior to that that'll kind of calm things down, make you feel like you maybe had a couple cocktails, and that can make it more tolerable. Or we can do procedural sedation, where you get an IV and we use medications to essentially have you sleep. If you've ever had a colonoscopy, it'd be similar to that. It's not anesthesia. There is no tube in the throat kind of breathing for you. And then I have one other question that we'll address as well. This is from Trevor. Trevor says, my back goes out several times a year, gets better after a week or 2 of muscle relaxers. Should I get my back treated when in pain or after? So this is a really good question too. So kind of the premise of this is there is some patients often complain of back pain that occurs periodically or it flares up with work. And so in an instance like this, many physicians will, again, essentially palliate the symptoms. They will give medications to control the symptoms until things kind of calm down. And sometimes that's even steroids by mouth. So, a little bit of muscle relaxers is probably not a bad thing. But again, remember, if the back is somewhat unstable because the ligaments are loose, that's the static system. That's not working. You're relying on your dynamic system, which is your muscles. And so now we're adding a muscle relaxer to that, which can further increase some of the motion, some of the wear and tear. And so certainly I would want to treat this as soon as possible. One of our hallmark principles is small problems require small solutions, bigger problems require big solutions. And you don't have to be in pain at the time of your treatment. We're going to be able to see some of that instability, again, with a thorough exam and some imaging. we'll be able to direct your treatment whether you're having current pain or not. But the longer you wait, the more that this instability is going to persist, and the more likely that we are to have any issues down the road. So those are the pre-questions that I had received. If anybody else has any questions, again, you're more than welcome to set them up, and I will just check real quick. I do not see any questions. So if anyone has any comments, you can certainly call or email us. If you have topics that you'd like us to address, please let us know. We'd be happy to cover that in the future. We'll be doing another webinar in about 2 weeks. I think we're going to cover carpal tunnel at that time. So if you have any questions that you'd like to send us in advance, please feel free to do so. Otherwise, I'll see everyone in 2 weeks. Thanks so much for joining us. Have a good one.